Well, good morning. I'll preface by saying I'm an hour earlier in time zones than you guys, and I'm not much of a morning person, so I'm going to take a complicated topic and make it understandable for you at the wrong time of the morning, but I'll do my best. So I'm very happy to be here, and this morning I'm going to talk about the kidneys, and especially I'm going to talk about Fanconi syndrome, lab tests, and kidney transplant. So I would like to say understanding the kidney is easy, but I know you know that's not true. It's really complicated. And you've probably found that in your discussions with some of your doctors. Some are better at explaining it than others, and I'm hoping that I try to make it a little more simple for you today. So I need to start with some basics about the kidney, and the first thing I'm going to talk about is the fact that the kidney is so important that it has many names in different languages. And so the Old English name for kidney is kidney, which is what we use because we speak English. But there's a Latin term for kidney called rene, and sometimes we talk about renal. And there's a Greek word for kidney that's nephros, so sometimes we talk about nephrology. And so that's why you go to the renal clinic to see the nephrologist about your kidneys. And we try to make it complicated for you to even know who we are. So the kidney is located in your body in the back part of your abdomen. And it's the organs here in red. And it's protected by a big, thick layer of muscle around your spine. And so it's really not so hard to get an injury to it. The kidneys are connected to the bladder with a tube called the ureter. And the bladder is a receptacle that holds the urine until you're ready to dispose of it in the bathroom. And that whole system of the kidneys, the ureters, the bladder, is called the urinary tract. So what does the kidney do? Well, it does many things. It filters the blood, which means that it's just like a filter. It keeps the large particles from going into the urine, and it lets the smaller particles go into the urine to be sorted out by the parts of the kidney. And so what the parts of the kidney do is they then resorb back into the body the substances that you need. So you need to return some and regulate bicarbonate and salts like sodium and potassium and minerals like calcium and phosphorus and fluid. The kidney also recycles proteins and albumin, low molecular weight proteins, amino acids, and glucose. Besides doing that, it then excretes in the urine what your body doesn't need, and it excretes some waste products. One of them is called creatinine, and it's a waste product from muscle metabolism, and we use it as a marker for kidney filtration. It gets rid of excess fluid. It gets rid of excess acid. It gets rid of excess sodium and potassium, so you can eat pizza and French fries. It gets rid of excess calcium and phosphorus, so you can eat all kinds of dairy products and meats and dark colas. So the kidney is responsible for keeping your body chemistry normal at all times by getting rid of the excess that you don't need from your diet. Now, what happens, what else does the kidney do? Because it's really a pretty busy organ. It also produces some important things, and one of the things it produces is a hormone called erythropoietin, and that's a hormone that tells the bone marrow to make red blood cells. So who would know that the kidney had anything to do with your red blood cells, but it's a very important thing. The kidney also takes the vitamin D and turns it into the active form that you need to make strong and healthy bones. And finally, the kidney also regulates blood pressure by producing a hormone called renin that can raise the blood pressure when you need it. And then it excretes excess sodium and fluid so that you don't have high blood pressure from too much volume overload or salt overload. and it removes medicines and drugs and toxins like poisons. So the kidney has so many things to do. So how does it do those things? Well, it does it because it's got a lot of filtration units. So this is a kidney cut lengthwise, and what you can see here is the area that collects the urine to go down the urine tube to go out. And this part, this red part, is all functioning nephrons. And those are the filtration units. And each kidney has 1 million of those. And they have many specialized cells to do all the work. So if I take just one of those nephrons and blow it up, it looks like this. I said it was complicated. So the nephron has a filter that's called the glomerulus, and you can see this clump of blood vessels in the middle of this sort of cup-shaped tube, and that's where the filtering goes on. And then to do all the reabsorption, it goes to a very convoluted kind of small tube that's called the proximal convoluted tubule, and that is what is affected badly in Lowe syndrome. So when the proximal tubule doesn't work well for a long time, it then becomes sick, and it makes the whole nephron sick, so it makes the glomerulus not function anymore, and that's why you get kidney failure over time from Lowe syndrome. So the proximal convoluted tubule has a big job to reabsorb about 80% of the filtered substances that come through that filter. And it does that through a group of specialized cells that look like this. This is a cross-section under the light microscope, and you can see all of these little circles are the nuclei of these cells. And if I look at the cells under the electron microscope, where I can see it a little more, I can see it has a lot of brush border here. It has a lot of organelles that help it do its work. And so if I look at one of those cells, here's a 3D model of what the cell is doing. And this cell is designed so that it can have a lot of reabsorption ability, and that's done because it has all of these little finger-like projections, which we call a brush border, which greatly increases the surface area that comes in contact with the filtrate, so it can reabsorb all those things that you need back into your body. Besides doing the reabsorption, it also reabsorbs in a different way albumin and small proteins. And that's done through these little coated vesicles that are shown in the purple circle here that are a little more to the side of the cell. And then the kidney also has an organ called a mitochondria, and those cells produce energy for the cell to do all the reabsorption, and they also produce the active form of vitamin D. So this is a very, very active part of the kidney, and that's why when it goes wrong, things are not so good in Lowe syndrome. So what is abnormal in Lowe syndrome kidneys? Well, because reabsorption is not so good in the proximal tubule, you have less reabsorption and you lose excess things in the urine that you shouldn't be losing. You lose bicarbonate, which leads to low blood bicarbonate and an accumulation of acid in the system because bicarbonate neutralizes the acid. You also get a low phosphorus in the blood because you don't resorb enough, and that may cause rickets and growing bones. You also lose sodium and potassium, so you can have a low blood sodium and potassium, and those are very important to regulate everything else that runs in the body. We see an excess of low molecular weight proteins, albumin, amino acids, and glucose in the urine. And these don't cause any clinical problems, but they are markers for the kidney disease. And then a lot of excess calcium is lost in the urine, and it also accumulates in the kidney in places that it shouldn't be, and it can cause kidney stones and calcifications in the kidney. So besides less reabsorption, there's also less production. So you may make less of the calcitriol, that active form of vitamin D you need for your bones. And then as time progresses into the second, third, and fourth decade of life, there may be decreased filtration from the injured glomerulus. And that causes an increase in waste products like creatinine and blood urea nitrogen, or BUN. And that causes what we term chronic kidney disease, or CKD. And CKD progresses from stage 1, which means things are working well, to stage 5, where things aren't working at all and you have to do dialysis or transplant. The progression is usually very slow in Lowe syndrome, happens over years, so you're not going to be surprised that you come in for one visit and the next visit things are bad. It's going to go very gradually. And then you may see poor excretion of some medicines and drugs that are handled by the proximal tubule, and your doctor needs to know about those. For example, pseudoephedrine, which is in some cold medicines, may accumulate because it's not excreted well by the proximal tubule. And so you can get side effects from high levels of that. Pseudoephedrine is a decongestant that's an over-the-counter cold medicines, and you probably should avoid those. So we monitor the kidney function in Lowe syndrome with lab tests. And I'd like to say that's simple, but you know that's not. It's complicated. And when someone goes over the lab results with you, sometimes I'm sure you may not completely understand, but I'm going to try to make it a little easier for you today. So what comes out from the lab is a lab report that may look like this. This is from the Quest lab, which is a national lab. And it has a whole list of lab tests on one side. And then it tells you which results are in range, and you can see that in the column under the blue circle. And it tells you what's out of range, which is the column under the red circle here. And then it gives you a reference range of what should be the normal range. Now, many of you may be using my chart in the electronic health record now, and it looks different for lab results. So in this case, the lab results are shown graphically. And so in this case, the bars below the numbers have a green area and a yellow area. And the green area is the normal range, and the yellow areas are too high or too low. So in this case, the white blood cell count is normal. It's in the green range. But the hemoglobin is low because it's in the yellow range. And that's how you read those charts. Now, as a physician, I get to look at a flow sheet. So this is very useful for the nephrologist taking care of your child, because I can look at the lab results for dates over time. So you can see here's the date up here, and here are the lab tests. And it shows me in red what's abnormal, and it gives me either a low H or a high to know whether it's high or low compared to the normal range. So it's very useful for me to see what's happening to your lab results over time. And sometimes I print these out and hand them to my patients because I think it's easier for them to understand as well. So now I'm going to go by lab tests by the problems that you have in the kidney. So I'm going to start with the Fanconi syndrome. So the Fanconi syndrome is a funny name, and the question is, what does it really mean? Well, it's abnormal reabsorption by an abnormal or diseased proximal tubule. And this can happen in a number of diseases, including Lowe syndrome. And so the Fanconi syndrome refers to wasting in urine of bicarbonate leading to acidosis, of phosphorus leading to low blood phosphorus, of sodium, potassium, calcium, amino acids, glucose, and small molecular weight proteins. So why is it called the Fanconi syndrome? Well, its real name is pan-proximal kidney tubule reabsorption dysfunction. And that is too hard for even physicians to say. And so it was described in 1936 by Dr. Guido Fanconi, who's a very famous Swiss pediatrician. And he described this syndrome in another disease called cystinosis. And because it's so hard to say, this syndrome has been associated with his name. Dr. Fanconi was really the father of modern pediatrics, so he's near and dear to my heart in many ways. But he described so many things that over his long career, that there are other things named after him, like the Fanconi anemia. And sometimes physicians get confused when you're talking to them, and they think you mean the Fanconi anemia when you really mean Fanconi syndrome. So I often refer to it as the renal Fanconi syndrome or the kidney Fanconi syndrome, just to make things clear. So the lab tests that we get to monitor the Fanconi syndrome include blood chemistries and urine tests. And the blood chemistries we do from blood that's taken and put in these kind of tubes, and then it's spun in a centrifuge to separate out the serum from the blood clot. And the serum is then taken to the chemistry lab to run all the tests. We also look at the urine, and we do a urinalysis with a dipstick, and that can be done in your clinic. We do that in our clinic, but also in the main laboratory. Or we can look at samples of urine to measure protein, creatinine, calcium, and any other substances we want to. So the panel, usually for the lab tests for chemistries, they come in panels. And the panels have a number of tests run through one machine. And the panel I like best for Fanconi syndrome is called a Chem10. And the reason for that is that it has a magnesium and a phosphorus already done on the panel. And unfortunately, the Chem10 is not available very much in many hospitals. And what you get instead is what's called a basic metabolic panel. And the basic metabolic panel does not include the phosphorus. And that's really bad for Fanconi syndrome, because if doctors are just ordering that test and not looking at the phosphorus, they're going to miss low phosphorus in the blood that might need to be treated with phosphate supplements. Another very common test is the comprehensive metabolic panel, which has 14 chemistry tests. And it also has extra things like albumin and total protein that are helpful in monitoring the Fanconi syndrome. But it, again, has no phosphorus, so your doctor has to be sure to order a phosphorus. And if your doctor's not looking at phosphorus and you're not seeing those results, you need to tell them they need to order that extra. Also, if you're on medicine to treat either the acidosis with bicarbonate or citrate medicine or the phosphate medicine, those medicines are excreted in the kidney very rapidly, and that's why you have to take the medicine 2, 3, or 4 times a day. And when you look at the blood test, it depends on when you last took the medicine as to what the results are going to be. So in this case, if the medicine was taken an hour before the blood was drawn, that's called a peak. And you can see all the results here are in black because they look normal. But if this patient is taking the meds every 8 hours, and you look at an 8-hour medicine, which we call the trough, just before the next dose, you can see there's abnormal values. And so what I try to do is just to monitor the troughs rather than the peaks. So I'll want the blood test measured an hour before your next dose is due, or within the hour before your next dose, because I want to see what the worst levels are to make sure I'm keeping you in a reasonable range. We don't need to do peaks and troughs because that's too much blood draw for one day for your child. So you can't interpret the lab tests for Lowe syndrome boys or men who are on these medicines if you don't look at the time that they're drawn in relationship to the medicines. So the urine tests help us monitor a lot of things, and one of the things we monitor is protein. And as you know, all boys and men with Lowe syndrome have protein in the urine, and the dipstick shows that up as a value that is usually determined by whether it's 1+, 2+, 3+, or 4+. Sometimes we also want to quantitate how much protein is in the urine, and we can do that on a specimen, just a single sample, by relating it to how much creatinine is in the urine, and that's called the protein-creatinine ratio, and we have normals for that. And that's always abnormal in boys and men with Lowe syndrome. Sometimes we'll want to measure further. Before I get to that, even though there's protein in the urine, and even though there's high protein related to the creatinine, these boys always have normal albumin. And that's very different from other kidney diseases that have protein in the urine, where the protein loss leads to low albumin. And so I need to talk to you more about what the proteinuria is here. So protein in the urine, or proteinuria, is very complicated. The glomerulus filters albumin and low molecular weight proteins from the blood, so they always go into the urine of normal people, and as well as those with Lowe syndrome. The proximal tubule then reabsorbs those filtered albumin and low molecular weight proteins, so that by the time you look at the final urine, you don't see any albumin in the urine, okay? And so the normal proximal tubule leads to no proteinuria. If you have an abnormal proximal tubule reabsorption, you're going to have tubular proteinuria, and that is what we see in Lowe syndrome. If you have an abnormal glomerulus, you might filter too much protein, including large proteins as well as the small molecular weight proteins, and that gives you protein in the urine that we have correlated with ongoing kidney injury. And that's called glomerular proteinuria. And we see that especially in diseases like diabetes, hypertension, glomerulonephritis, and nephrotic syndrome, which are the common diseases that nephrologists see. So they're all tuned into glomerular proteinuria, and they want to treat it like glomerular proteinuria, but the boys with Lowe syndrome don't have that. They have tubular proteinuria. The urine dipstick just tests for albumin, so it doesn't tell you whether it's glomerular or tubular. And it can be positive with tubular or glomerular protein. And so you need to understand that what these boys have is tubular proteinuria and not the glomerular proteinuria that's treated in a different way. So tubular proteinuria includes albumin, but it also includes low molecular weight proteins like beta-2 microglobulin, retinol binding protein, and lysozyme. And these are things we don't measure and we don't look at. We might initially on presentation, but they don't help us really take care of you. They're just markers that the proximal tubule is not handling these proteins well. And they don't deplete you of these proteins, so they don't really cause a problem. They're just a marker for tubular disease. Other labs for Fanconi syndrome include amino acids in the urine. So the building blocks of proteins are these substances called amino acids. And they group together, a few of them group together to make a peptide, and then these peptides coalesce to make protein. And as the proteins break down, they release amino acids again. They go into the blood, they go into the kidney, and the kidney has a chance to reabsorb those so they can be reused, okay? And what happens in the Fanconi syndrome is that the amino acids aren't reabsorbed in the amount that they should. They come out in the urine, and so you have generalized amino aciduria. But the blood amino acids stay normal. So it really doesn't cause any problem, but it's just a marker for proximal tubule dysfunction. The same is true for glucose, okay? So glucose is high in diabetes, and because it's high in the blood in diabetes, it causes blood sugar in the urine. In this case, we may see glucose or sugar in the urine, but it is not from high blood glucose, it's from tubular dysfunction. And so it can be confused with diabetes, but you measure the blood sugar, and if it's normal, you know it's a renal origin and not diabetes, okay? So the importance of both the amino acids and the glucose is that they're markers for proximal tubular dysfunction, and they help the doctor make the diagnosis of the kidney Fanconi syndrome. And usually we don't get them again, we don't get the amino acids after we first make the diagnosis. We may see sugar in the urine because we do a urinalysis and it's on the dipstick, but we know that the blood level is normal so that it really is not diabetes, okay? And many of the boys with Lowe syndrome do not have glucose in the urine. It's only a small fraction, about 10 to 15%, as opposed to other diseases that have the Fanconi syndrome. So another lab test for the Fanconi syndrome is carnitine. And carnitine is the substance in the body that helps with general functions to keep blood pressure normal and a lot of other things. Carnitine's function is to transport fatty acids into the mitochondria of cells. Remember those little red organs I showed you before in the proximal tubule cell? And they're used to generate energy in the cells. So without carnitine, things can be bad. So carnitine can be lost in excess in the urine, and that can lead to carnitine deficiency. That doesn't happen very often. It happens probably in a third or less of patients with Lowe syndrome, and sometimes it's only intermittent. You can get the blood carnitine one time it's normal, the next time it may be a little low. And so it comes as a panel that includes other metabolites of carnitine that the doctor can interpret. And sometimes you need carnitine supplementation, and that's followed with these carnitine blood levels. Okay, so now I'm going to move on to how lab tests are used for kidney bone disease. And a normal bone has, looks like this one that's cut in half, and you can see there's this blue stripe in here, and that's the zone, cartilage in the zone of calcification. And what happens in Fanconi syndrome is that sometimes that zone of calcification doesn't calcify normally because there's not enough calcium and phosphorus to make good bone. And so what you get is what's shown here in the yellow areas, which is enlargement of those growth plates in growing bone. Now, this only happens in growing bone, so you're not going to see this after the growth plates are closed and the boys get to adult height. So what causes this kind of bone disease? Well, it can be caused by acidosis, okay, from not enough bicarbonate in the blood. And that, if there's too much acid in the system, the body then has the bones help buffer the acid. So the acid particle goes into the bone and displaces normal bone. And so it can make the bones abnormal. Also, in Fanconi syndrome, you get low phosphorus. And when you don't have enough phosphorus, you don't lay down enough calcium and phosphorus to make good bone. Also, you may not make enough vitamin D. Although most of the patients I see with Lowe syndrome, I measure the vitamin D levels and they seem to be normal. It gets even more complicated because there's a whole system in the body to protect the calcium level. And that system includes these little tiny yellow dot glands in the neck that are next to the thyroid. They have nothing to do with the thyroid, but the Latin word for next to is para, so they're called parathyroids because that's where they live. And they have everything to do with calcium metabolism. And so you make parathyroid hormone, or PTH, which goes to the kidney to reabsorb more calcium, the bone to take calcium out of the bones, to keep the calcium level normal in the body. And the big reason for that is the heart needs calcium normal at all times to function normally. And if your heart doesn't work, you don't work. And so that's why parathyroid hormone is important. The next thing is the liver takes the vitamin D you take in your diet or make in your skin, and it converts it to a compound known as 25-hydroxyvitamin D, which is the precursor of what the kidney makes, which is the active form, or vitamin D 125 dihydroxy, or calcitriol. And that goes to the bones to tell them to put down more calcium and phosphorus, to the gut to tell it to absorb more calcium and phosphorus, and to the parathyroid gland and say, stop producing parathyroid hormone, we're going to take care of it. We're going to make the calcium and phosphorus better. So it's a complicated system. Now, a reason I go through all this is that's because we do all these blood tests to follow the kidney bone disease. We want to know whether you're acidotic, we want to know whether your phosphorus is low, and we want to know whether your PTH is too high or normal, and we want to know that your vitamin Ds are okay. So those are blood tests we do for bone disease, okay? We do the same blood tests for kidney stones and calcifications, okay? So some of the boys, about 40%, get calcifications, and they can be either stones, like you see here, or they can just be calcification in the tissue, which you can see here, okay? The calcification in the tissue is called nephrocalcinosis. Nephro means kidney, calcinosis means too much calcium in the kidney, okay? So as I said, this occurs only in 25 to 40%, and only some of those with high calcium in the urine have stones, and we don't know the reason for that, but it might be related to whatever their mutation in the gene is. Also, we know that immobilization, if you're not getting up and being active, low physical activity leads to loss of calcium in bones. So get those boys up and going if you can. So sometimes if they have kidney stones and they pass them, we like to do an analysis of what they are. And the most common kidney stones are calcium oxalate stones, and we sometimes see that in Lowe syndrome, but most of the time what we see are calcium phosphorus stones, and that's because there's too much calcium and phosphorus in the urine. So sometimes the nephrocalcinosis can cause inflammation in the kidney, and that can cause there to be blood and white blood cells in the urine. And you can see they're showing here in this urinalysis in the red as 2+ blood and 1+ leukocytes. And those are also the hallmarks of infection. And so if you take your boy to the emergency room for an illness and they look at the urine and they look at that, they're going to say, oh, this is a urinary tract infection. They're going to try to treat that. But if they have nephrocalcinosis, you can't treat on that basis. You must do a urine culture. And so you have to know whether your boy normally has blood and white cells in the urine from inflammation. And you need to do cultures if there's going to be diagnosis of an infection. The other thing we often do for those with stones is look at the calcium to creatinine ratio just on a sample of urine. And that can tell us how high the excess calcium is. And sometimes we also do a 24-hour urine so we can see exactly how high the calcium is in the urine. And while we're doing that, we often do measurement of creatinine or a creatinine clearance, so that can tell us about the function of the kidney as well. So that's the measured creatinine clearance, or the glomerular filtration rate, the GFR. The important thing is that the absolute GFR often looks low in children or in smaller sized adults because they don't have as much kidney mass as a bigger person does. And so we know to correct the creatinine clearance to the size of the patient. So in this case, if the actual absolute clearance was 67, that's very abnormal, and that would be CKD3. But when we correct it for body size, it's normal, and so pediatric nephrologists know to do that. Internists often don't, because they just deal with adults. So There's some other tests you need to know about as well. So sometimes liver panel tests are done, liver tests, and you may see in a boy an abnormal AST or an alkaline phosphatase, which are liver enzymes. But you know what? The AST is also made in muscle, and the boys with Lowe syndrome have abnormal muscle, so that AST might just be high because of their muscle and have nothing to do with the liver. The alkaline phosphatase is also made in bone, and so if the bones are having problems with rickets or decreased mineralization, or when they're healing of rickets with therapy, the alkaline phosphatase may be high, and that again has nothing to do with the liver. And finally, the AST and the ALT may be high transiently with some viral infections. So your doctor really needs to interpret these tests, and you need not to get hysterical that the liver is now going bad in Lowe syndrome. It may just be other things in play. So I'm going to talk briefly about chronic kidney disease, which is how we classify how well your filtration function is. And the filtration function is usually measured by the glomerular filtration rate, which we estimate most of the time from either blood creatinine or from a molecule called cystatin C. And we have formulas to do this from the blood tests, and these formulas are different for adults and for children. And sometimes we also want to measure a 24-hour urine to be sure we get it right. So these are the stages of chronic kidney disease. Stage 1 is normal function, and everybody would like to have that. And boys with Lowe syndrome often always have normal function during the first 10 years of life. By the time it gets to stage 3, you're beginning to see loss of kidney function that needs to be looked at from a chronic kidney disease perspective. And when you get to stage 5, which is less than 15% glomerular filtration, then you have kidney failure and you need to think about dialysis and transplant. The stages of chronic kidney disease are also broken down by how much albumin is in the urine. So these were developed for the bulk of the population that has glomerular proteinuria, not tubular proteinuria. And as I said before, albumin in the urine is a very bad marker for CKD and Lowe syndrome because it's tubular albumin and not glomerular albumin. So Lowe syndrome patients always have a high urine protein creatinine ratio because of the tubular disease, and that doesn't necessarily mean they have worse kidney failure. So the other thing that we have to take into account is that the substances we use to estimate the GFR are creatinine and cystatin C. And creatinine is a breakdown product of muscle metabolism. Creatinine also comes from meat, and it's ingested and excreted by the kidneys. And it is easy to measure in blood and has become a good marker. However, because the boys with Lowe syndrome have low muscle mass, they have a lower creatinine, and that makes their GFR look better than it actually is. So it's probably better to look at cystatin C, which is another marker substance that's found in all tissues and fluids, but it's not dependent on muscle mass or age or diet. And the newer formulas all use creatinine and cystatin C or cystatin C alone. The estimated GFR is done by formulas. And for children, we have the Schwartz formula, which requires that we have a serum creatinine and a height, as well as a urine creatinine. And then the CKID U25 is for children up to 25, and that also incorporates cystatin C and takes into account the height, the age, and whether it's a male or female. And then for adults, we often use the CKD epi creatinine or cystatin C formula. So these formulas are well known to your nephrologist, and it's a little bit of a problem for us who take care of those over age 25 with Lowe syndrome who may be small for age and not quite fit the adult normals. And so we have a lot of trouble estimating what actual normal is. So if you see the lab report from Quest, it usually will say what the GFR, estimated GFR, the eGFR is, but if the patient is less than 18, it says unable to calculate. But Your pediatric nephrologist can calculate it, it's no problem. And we know to correct it for body surface area, and the normal adult body surface area is 1.73 meters squared. So CKD labs look a lot like Fanconi syndrome labs, except you can see we have to do the magnesium and phosphorus, and we've added in the cystatin C. And you can see that the markers, other markers for kidney function, like creatinine and blood urea nitrogen, are high when you have CKD. We also need to look at parathyroid hormone and vitamin D levels because they're abnormal in CKD. The other thing that happens in CKD is you don't produce enough erythropoietin. And so you begin to see anemia, so you have to look at a CBC. And the anemia is really measured by the hemoglobin and the hematocrit and the red blood cell count. Sometimes because the red blood cells in chronic kidney disease don't last as long as normal, you have to make more and make them more frequently, so you need more iron. So we also know to look at blood tests for iron, and we look to see whether the iron level and the percent saturation is normal. In about 20% of boys, unrelated to chronic kidney disease, we might find a low platelet count, and that low platelet count really is common to Lowe syndrome in about 20% of patients and has nothing to do with chronic kidney disease. But you'll pick it up because you're doing CBC. Well, I said it was complicated, but I hope now you think it's not that complicated. And I hope you're feeling a lot smarter now.